Welcome to RyView's special 4-part series on substance abuse. Substance abuse has become a critical concern in a countless number of communities, and our wonderful city of Rye has not been immune to its harmful and tragic outcomes. Our expert guest on this episode is orthopedic surgeon Dr. Lewis McIntyre. Dr. McIntyre has an office in Sleepy Hollow and has been practicing medicine in Westchester since 1994. Needless to say, many surgeries can be invasive, with a patient experiencing a significant amount of pain as a result, needing narcotic medication. The overprescribing of pain meds has become a very important topic in the war on drug abuse. Pain management is a vital part of a treatment that must be monitored more closely.
Dr. McIntyre is very concerned about the pill addiction epidemic and is optimistic about the efforts being made to decrease the risk of abuse and dependency. He explains in detail the new stricter mandatory guidelines that are being enforced for doctors prescribing narcotic medications, along with alternative ways of managing pain. Dr. McIntyre sheds light on the importance of doctors engaging in the discussion of narcotic abuse with patients and with younger patients, the requirement that parents be involved in that discussion. All right, so we are sitting here with Dr. Lewis McIntyre. Thank you very much for coming along. Dr. McIntyre is an orthopedic surgeon based in, well, you live in White Plains, but You're working in the area. So we were just wondering from your perspective, you know, when kids get an injury and they are prescribed painkillers, do they go home with any framework on how to use them? Is there, like, do they use 2 and stop? Do they go home with 30 and it's up to you? How do you doctors prescribe it to the kids?
Well, thanks for inviting me, number one.
Yeah.
And children or any patient who gets a narcotic prescription gets, a labeled prescription with instructions on how to take the medicine. It's usually 1 or 2 tablets every 4 to 6 hours, depending on the protocol the doctor uses. And then there's a limit on the amount, obviously, of the pills you get, and that depends on the doctor also. So it's really more to form of habit of the prescribing physician, which is one of the problems, because if you look at the data, the average prescription for narcotic medications is about 30 tablets.
In one
sitting. So you get a bottle and you have 30 pills.
So this might be something post-surgery.
Right, post-surgery. For my tenants, I'm an orthopedic surgeon, so what I do is actually quite painful. So for patients, so it's they require pain medicine in some way, shape, or form. Mm-hmm. So the average prescription is about 30 pills per, but the average patient takes only 10. So there's 20 pills sitting around.
Right.
And one of the big problems with narcotic medications is that most of the people who use them and get them from a friend. That's about 55% of the people that recreationally or abuse narcotics get them from someone else. Where do those pills come from? They come from the leftover pills of the prescriptions that I give to patients, and that's a real concern of mine, and a concern of my orthopedic and other doctor brethren. Because we're, unfortunately, a lot of this problem is doctor-driven, and that's one of the reasons is all this excess medication that's sitting out there.
So if everybody gets 30 and majority, we say take 10, why are we prescribing 30 and not 10?
Well, I think it's more habit than anything else. And it's, doctors, they want to make sure patients have a reservoir of medicines if they need them. You can never tell when one person is going to need more than 10. I mean, 10 is an average, and averages are what they are. So I think that, plus prescribing the medicines now, there's many steps we have to go through to do that. And some consider that an onerous burden and are reluctant to go through it multiple times.
Let's talk about that. How it's changed. You were saying that there's a whole system now in place.
Sure. So as of this problem has been percolating for 20 years, and in the last 5, we've really started to do something about it. And New York State took a lead in 2013, and they passed legislation called iStop, which required that all doctors access a database that resides in Albany with prescribing our opioid prescription information. So before I prescribe an opioid narcotic, I have to log on to the Health Commerce System website and get into the iStop site and the Prescription Management Program, or PMP. I there have to enter the patient's name and birthday, and the prescription that they're going to get pops up. And any prescriptions they've gotten in the last several months pop up also.
So their entire list
correct,
of...
yeah, so the list of narcotic medicines, not of other medications, but only of scheduled medication, scheduled narcotics. So there's 5 different schedules according to the DEA, the Department of the Drug Department in the federal government, Drug Enforcement Agency, and there's 5 different schedules. So all 5 schedules need to be reported into iStop. In addition to that took place in 2013. In 2016, this year, as of March, we had to prescribe narcotics only through an electronic medical record. So the only way I can get a prescription for a narcotic medicine to a patient is to enter it into an electronic medical record. So I have to be sitting in front of my computer. I have to get into that system's prescription program, enter the narcotic. Then I have to attest that I've accessed the iStop system. And then I have to get a little token that's generated usually on a cell phone. So you get into a program that generates the tokens are numbers, and they keep changing every minute, so that it's a step to make it very difficult to sort of game the system or to use it illegally.
So you've gotten a lot more control then compared to, say, 5 years ago.
It takes a lot of time. So if I have to prescribe, it takes about 3 to 4 minutes to do that. Mm-hmm. But if I have to do that 10 times in a day,
taking up a lot of
time.
time.
As opposed to just this.
Right. But it's also a tracking mechanism, I'd imagine, about opioids that are out there and who has them. Or,
sure. Yeah. I mean, New York State's sort of taken a lead in this, and there are several states now. I think there are 7 or 8 states that have systems like this. Georgia, Rhode Island, several others. I looked at it as sort of an onerous burden when I started doing it, but when I started in the last several months, when I've become much more interested in this topic as a problem, mm-hmm. I've sort of reversed my thinking about it to the point where I think that this is actually something good. I think that something that decreases the number of prescriptions that out there is good. Something that makes doctors more aware of the potential harm of these medications is good. And, it's doing its job. If you look at the data from the Department of Health...
That's what I was just going to say. Is it working?
Yes. The incidence of narcotic prescriptions from 2010 to 2014 has stabilized, but certain medications like hydrocodone have fallen off significantly, and others have taken their place. So, for example, there's a medication called Tramadol, which is a much milder narcotic, which much less potential for abuse. The prescription rate of that has gone up like 30-40%. Hydrocodone has fallen significantly, so that's probably a good thing. I think doctors are a lot more willing to engage their patients in discussions about narcotic abuse and more willing to use multimodal ways to deal with pain. So instead of using a narcotic as a first-line drug, well, maybe we'll try a nerve block augmented with some anti-inflammatory medicines and a narcotic if necessary.
So starting out slower. So is there education, though, for the doctors on this? This has become, as we say, a growing epidemic. What are we doing to... Are you aware
there's mandatory opioid prescribing classes that are done online for doctors.
They helpful?
I think they are. I think that in reality, you can take a lot of courses online. I think it's going to take more doctors speaking out on this issue and becoming aware of the potential problems, and not the potential problems, but the problems that really truly do exist, and the fact that at the root of it are a lot of good intentions. We're just trying to solve people's problem, their pain, but in reality, we're contributing to a problem. So we need to be cognizant of that, and we need to change our behavior accordingly. So now, instead of just handing, or not, well, I can't hand it to them anymore, I have to e-prescribe it to them, but instead of just e-prescribing a narcotic prescription, I engage the patients in a discussion of what we're going to do to mitigate their pain. And that's going to include a lot of different factors. It's going to include anti-inflammatory medicines, the nerve blocks that we've been using for a while, other medicines that we can use that are non-narcotic. And we're going to limit the amount of medications we give them. We're not going to give them the 30 pills. Maybe we'll give them 20 instead of 30. And especially the younger patients, we're going to bring their parents into the discussion too, because the parents are obviously very concerned with this this new problem, not a new problem, but this problem that exists.
Can you get it from anywhere other than a prescription? Like opioid, narcotics, like if you want OxyContin or something, does it have to come from a prescription?
Sure, not legally. You can't procure these medications any other way than by a prescription legally.
Right.
You certainly can obtain them illegally. They're sold on the street. I mean,
That's
the 55% that you were saying
right,
before.
Correct. I mean, that's been there. Where do those come from? Well, they come from excess pills. Not all of those are excess pills, but a lot of them are, and in a black market that exists.
Do you find that the anti-inflammatories, the Aleve, the Motrin, are as successful for some of these painful surgeries like this knee?
No. I mean, obviously, they're not, and that's why the narcotics are there. I mean, if all pain was alleviated with anti-inflammatory medicines, there'd be no need for narcotics.
Right.
So certainly, especially for more painful things like fracture work. I mean, when you break a bone, that's incredibly painful. Or rotator cuff surgery or something like that. These are painful things, and they're not going to be completely. The pain is not going to be alleviated completely by anti-inflammatories. But if you just take the edge off with the anti-inflammatory, you'll decrease your need for the narcotic medications. Right. And the whole idea is to limit the amount of narcotics we're giving people. Right? We're going to limit the amount we're going to give them. We're going to limit the time frame that we're going to give it to them in. Because obviously studies have shown that the more narcotic you give and the longer you give it for, both those things increase the risk of abuse and dependency.
Do you often invite them back when you have when they need a refill or whatever? Do you invite them back to see if there's a possible addiction? Is that something that
I haven't been doing that. This is something that's really come to my attention more in the last 5 to 6 months, and so I'm in the process of changing my prescription behavior even now. As a result of what's happening in our neighborhoods. Mm-hmm. So I don't do that, but I am a lot more willing to say no now. So where in the past, if someone was in pain, and despite the fact that maybe it was past 3 months past their surgical procedure, I would be reluctant not to give them medications because, one, I want them to be satisfied and I want them to be free of pain. And two, there's a lot of orthopedic surgeons in town, and they can just go down the street and get it from somebody else.
Right.
So, but now I just say no. I say we're not going to give it to you, and it's become easier to say no because this has become a problem. So everybody's aware of this. They're not. They can be mad at me in the past, and they were, but now they can be mad at me, and I don't care.
Right.
Because they're. I'm certainly maybe contributing to a significant problem for them if I continue to give them narcotics. So if you look at the orthopedic studies are pretty good, and they show that if a patient with an orthopedic problem is on narcotics for more than 3 months, then they're twice as likely to be on narcotics in 5 years. 5. Imagine that's sort of that's a dependence. So 3 months seems to be a pretty good endpoint. So I don't prescribe any narcotics after 3 months at all, and I'm trying to do it for less than 2. Does that always work? No. But
everybody's
it's a
pain
goal,
is different,
right?
and
I think doctors are paying a whole lot more attention to those time frames.
Because did anyone really know that this opiate addiction would become so big and so out of control? I mean, the chemistry from going from pain post-surgery to I want to fix, that's just changing in the brain, is it?
we've always known of the abuse and addiction potential of narcotics. I mean, you're taught that in pharmacology in medical school. I think where we lost track is in the early 1990s, there was a trend in the pain management literature that said that it was okay to prescribe narcotic medications and that their abuse potential was minimal. And there were some studies that came out of various institutions, some of them around here, that said that, hey, this is not a big deal and we should be using more narcotics to treat our patients so that they're out of pain.
Now that that was something in the pill, actually, and what's happening is people are crushing it, but they're using it differently than it was its intended juice.
I'm sorry?
I would say what Dr. Skip said before was that it was given in pill form where it had that slow reacting or slow releasing thing that may have made it not so potent. But that's not how it's being used, right? Some people are crushing it.
They can snort it. They can do whatever they want.
Probably when they get to the addictive stage.
I think my comments would be more of the usual use of the oral ingestion of these things as a pain medicine. So that's a small subset of abuse.
Right.
Then there's going to be the whole intravenous abuse. That's a whole different kettle of fish. And then abuse through different means of taking the medicines. I think that it's going to be a whole lot harder to stop the latter two than what I'm talking about. I think it's going to be easier for me to prevent the abuse potential of somebody who gets narcotics because I've performed surgery on them than it is to reverse what Skip was talking about in terms of someone with a chronic pain problem who gets hooked and then is really in trouble. I don't see those patients in my practice. They're certainly out there, and unfortunately they're probably a larger percentage of the people we're talking about.
So you don't get to see some of the signs. Maybe it's really you're more of the beginning stages.
Yeah, I mean, I don't. If you're in withdrawal and you're in an orthopedic surgeon's office, you're in the wrong place.
Right.
So what about the parents? Like, so say you have a kid that comes in for shoulder surgery or whatever, and you send him home with the 30 Vicodin or whatever it is. What are your guidelines to the parents in terms of monitoring the 30 pills, or do you just only take it for the first 2 days, or what's your guidelines to them?
So first off, we employ a nerve block for all the shoulder surgeries. So we do what's called the supraclavicular nerve block. It's performed with a needle. They do it under musculoskeletal ultrasound guidance, so they get right down to the place where the nerves are. We inject that with a long-acting medicine like Novocaine, And that lasts for about 24 hours. And usually the first night is the worst pain that you have when you have shoulder surgery. So that usually mitigates the pain. And most of the time they don't need any pain medicine at all, especially the young men tend to tolerate the shoulder surgery pretty well. It's the guys my age who have their rotator cuff fixed. They're a little tougher to deal with.
But that's not addictive at all. That's just
no. It has
it's
like getting the Novocaine, correct?
Right.
And that wears off after 24 hours. And we say, well, in addition to the nerve block, we're going to start some anti-inflammatory medicines, and we're going to know that when the block wears off, you're going to have some pain. So you're going to take the anti-inflammatories, and we're going to use some ice. You have ice machines that we can use to circulate cold water around the joints, which is effective. And then if you need the pills, you take the pills. And I tell them that. I said, I don't want them to be in pain. You would take them if you need them, but limit the use to under 8 pills a day, and try to do it only every 4 hours, and then I'm not going to prescribe the medicines for them probably past 4 weeks. And the young people that I take care of rarely. I can't remember the last young person I took care of who needed even more than one prescription. Mm-hmm. I'm just lucky, in that regard. But it's mostly the middle-aged fellow like myself who's got a rotator cuff tear, who can't sleep at night, is really having trouble, and that goes on for up to 3 months. I mean, he's a lot more difficult to manage than the young kids.
Is there any following or tracking of them after they've had a surgery of that we have any idea of anybody who goes on to then have the 3 weeks or 4 weeks?
Sure,
can
we
contribute?
collect outcomes data. Not everybody does this, but we collect outcomes data in our office. So I use a system called SOS, Surgical Outcomes Solutions, where the program sends out an email to patients and they fill out it's a patient-reported outcomes measurement tool. And one of the questions is narcotic use. So we have a pretty good handle on that as to how long people are using the narcotics. We've been tracking other, we track pain and function scores more than we track traditionally pain and function scores, but certainly in the last half year I've become much more interested in narcotic use too. So we're really keying more on that now also, and that's very powerful information.
So you can, you were saying, use different narcotics that don't have as much of a...
Well, yeah, there's, you can, for example, if you look at the state database, the incidence of this use of tramadol, which is a sort of a lesser narcotic, has really kind of gone up since the institution of iStop. And that's because it's a lot gentler, and people are a lot more likely to use it.
So why doesn't everybody use it?
Well, it's not as effective. The stronger narcotics are used for a reason. I mean, they work. If you've ever had severe pain, you know that the first thing you want is it gone.
Right.
You want it gone, and the narcotics are effective. And I'm sure you went over with Skip the whole mechanism of action and how they work and all that stuff. But it's not magic. It works. It's pharmacologically effective treatment.
And it's interesting how some become just a pill for them, and others it becomes.
Yeah, well, it's depending on the study you look at, anywhere from 7 to 15% of the people in a population are going to be predisposed to becoming narcotic addicts for whatever reason. There are some tools that you can use now, validated tools that can assess patients for the potential for narcotic abuse. There's one by a gal named Webster, and it's supposedly validated, which means it's shown to be accurate. In other words, if you adhere to their questions, then you'll be able to predict accurately who's potential for addiction.
And you do this before?
I do. I have not. I mean, I've just learned about this. Like I said, my whole approach to this has been changing recently, just because of things that have been happening in our communities. So
it sounds like the whole system is changing for the better. Like there's hope and there's a positive
I think so,
approach.
without a doubt. I was talking to Skip before, and about 4 weeks ago, I was talking to a fella in Massachusetts that I do some work with. We're working with some new equipment to take care of rotator cuff problems, and so we're culling all our data, and it's really kind of an exciting project. And he sent me a talk that he gave. He's on the northern border of Massachusetts with New Hampshire, and they're having a real problem up there with narcotic abuse. So he sent me this talk that he gave on narcotic abuse and the prescription problem, and I was like, wow, this is pretty interesting. And he's trying to spread the word, right? And then a week later, I got a similar talk from the American Academy of Orthopedic Surgeons, who are trying to make this a signature issue too, because obviously we are healthcare advocates, right? We are for our patients. So, and then I got a call from Cynthia about this program.
Okay, so it's happening.
This is something that's happening for the better, as you said. I think it's really, really for the better, and I think doctors really have to lead the effort because we're a big part of the problem.
Well, I think that you're also part of the solution. It sounds to
Without
me
a
like
doubt.
you are
Absolutely.
really
Yeah,
making it
absolutely,
out
yeah.
there. Something amazing. The awareness that you're just creating right here. We can't thank you enough coming on the show.
You're welcome, but
and
that's the
taking
whole
time.
point.
Yeah, but this patients taking the time to see the doses and whatnot. I mean, that's everything. That's all we can ask you for, right? You're trying to make us better, and
it's part of the job. I would say that you have to be. Even in a selfish way, the studies show that if your orthopedic patient is on chronic narcotics, their outcomes are worse, and they cost the health system more. Their incidence of complications is more.
so you haven't helped. You've turned right. So
So
it
from a
helps you
purely
to-
selfish point of view, I mean, it behooves us to pay attention to this problem purely from an outcomes measure approach. You know,
But you have so much more vested in it, we can tell.
well, yeah, it's
can
you know,
hear
I
it
mean,
in
when,
you.
like I said, when things start happening in your neighborhoods and you see young people of significant promise who get into real trouble, it's you know,
heartbreaking.
It's heartbreaking.
And it's everybody. Everybody's got that.
Well, it could happen to
No one
anyone.
is safe. And
Yeah.
I have
Right.
That's a big
5
takeaway.
children, and you know, in a selfish way, I'm certainly concerned about where they're going to be, and don't want this to afflict them. So.
Right. Well, thank you again.